I would like to share with you some of the information related to TAVR versus SAVR in younger patients. So what are the pertinent issues for TAVR versus SAVR in younger patients? The question is, what is young? Is it less than 70, less than 65, less than 60, or less than 50 years of age? We also have to ask ourselves, do comorbid conditions matter on the outcomes of the procedures? And then another question is, are we making a comparison of TAVR versus SAVR with bioprosthetic valves, or are we making a comparison of TAVR versus AVR with mechanical valves? And obviously, where is the evidence? So what are the known facts for mechanical prosthesis versus bioprosthesis? We know from previous studies and publications that mechanical prosthesis and bioprosthesis have their own advantages and disadvantages. When we choose mechanical prosthesis, it means lifelong anticoagulation and regular INR monitoring for safety measures. Also, there is enough information to show that there is a higher risk of bleeding with mechanical prosthesis. And by choosing bioprosthetic device, one entails the possibility of reoperation. Now, from this publication by Johnson and others, in 354 surgical explants in more than 12,000 patients after SAVR, we can see that, structural valve deterioration matters over a period of years and is progressively increasing over a period of time. We can also see from this publication that there is a higher risk of explant in younger patients, particularly those with high residual gradient after surgery. Now, what are the factors affecting bioprosthetic valve durability? Here are the examples of some of the bioprosthetic valves that are used in SAVR, but by no means all of them that have been used. And we can see that the type of the valve matters as far as complications, as far as structural valve dysfunction is concerned. And it depends on the valve design, tissue type, and tissue preparation and preservation. So there are known facts for mechanical prosthesis where bioprosthesis is concerned, where age and calcium metabolism matters. From this publication, the older patients, the slower the valve degenerates. And also life expectancy matters. From the STS database in more than 160,000 patients, the average post-AVR survival in patients more than 80 years of age is only 6 years. And then, of course, age and comorbid conditions play a significant role. So from the ACC-AHA guidelines, the recommendations are, on the basis of currently available information, for patients aged between 50 to 65 years, either a bioprosthetic or mechanical AVR is reasonable, depending on patients' comorbid conditions, risk of repeat valve surgery, patient preferences, and shared decision-making process. Now, as far as a meta-analysis that is shown here, in a large number of patients related to the early mortality, comparing bioprosthesis versus mechanical valves, there is no difference as far as early mortality is concerned. Another information from this particular meta-analysis, as far as freedom from bleeding is concerned, bioprosthesis versus mechanical valve, this study favors bioprosthesis as far as the risk of bleeding is concerned. Nowadays, there are patient-specific considerations for TAVR versus SAVR, and they depend on procedural mortality and morbidity as far as STS is concerned. It also, we have to take into consideration annulus size, coronary heights, and STJ width, as well as presence of coronary disease and also concomitant valvular heart disease, and also future procedures such as need for PCI, redo TAVR, or redo SAVR. And then very important factor is long-term durability as far as structural valve dysfunction or deterioration is concerned. We should also consider patients' preferences, and we'll discuss this briefly in more detail. And finally, all of those factors are taken into consideration and presented to a heart team decision-making process. As far as patient preferences for TAVR is concerned, one should take into consideration oral anticoagulant risks over a longer period of time, and also accompanied comorbid conditions that could be present in certain circumstances. Also, patients' work type of activities and life-related circumstances that might preclude patients from accepting mechanical prosthesis. There is also a potential risk or intolerance of anticoagulants. And also, one should take consideration of future options that the patient might need. So let's look at mortality and morbidity early and late as far as TAVR versus SAVR is concerned from randomized control trials. Here we can see from Evolut low-risk trial at 4-year follow-up as far as all-cause mortality, disabling, stroke, or rehospitalization is concerned, that SAVR offers worse results and Evolut TAVR offers better results at 48 months of follow-up. So in this particular study, there was a 26% reduction in hazard for death or disabling stroke with Evolut TAVR versus SAVR. In the Notion clinical trial at 10 years of follow-up with the core valve, we can see that the long-term mortality and all-cause death is similar between two procedures. As far as hemodynamics are concerned, we can see that core valve offers better effective orifice area and lower gradient at 5 years follow-up for high-risk patients, and also for intermediate risk patients, and also for low-risk patients. Now, when we look at the specifics, as far as a mean gradient of more than 20 millimeters of mercury is concerned, TAVR offers lower gradients than SAVR, and also there is a higher incidence of patient prosthesis mismatch with SAVR than with TAVR. As far as severe perivalvular regurgitation is concerned, it was not observed in either of those subgroups. As far as valve endocarditis is concerned, it was slightly higher in the SAVR group, and clinical or subclinical valve thrombosis was not a difference between two groups. As far as long-term durability is concerned from the randomized clinical trials are concerned, we can again see that TAVR offers a lower risk of bicuspid valve deterioration, and also as far as worse clinical outcomes are concerned, it's significantly worse for both SAVR and TAVR if you have a bicuspid valve deterioration. So bicuspid valve deterioration plays a significant role as far as outcomes are concerned on long-term basis. From this study, bioprosthetic valve dysfunction was associated with an approximately 50% increased risk of death, cardiovascular death, or rehospitalization in all TAVR and AVR at 5 years of follow-up. A Notion clinical trial has also shown, as far as severe structural valve deterioration is concerned, that there is worse outcomes on a long-term basis with SAVR rather than with TAVR. So one should take into consideration less invasive TAVR, which is currently standard of care, because benefits of less invasive TAVR offer reduced mortality and morbidity across the spectrum of TAVR patients. It can improve patient satisfaction and improve efficiency, such as reduced hospital expenditures are concerned. Here are the differences between less invasive TAVR protocol versus a current SAVR protocol. In patients with less invasive TAVR protocol, this procedure is performed in the cardiac cath lab under conscious sedation, percutaneous approach, and then the patient is monitoring on telemetry floor rather than in a costly ICU, and also reduced length of stay is less than 24 hours. SAVR protocol requires the patient's procedures performed in OR under general anesthesia, Foley catheter, NG tube, and chest tubes are usually placed. The procedure can be done with cut-down or percutaneous approach, but post-procedural monitoring typically is done in the CV recovery room, and typically length of stay is more than 4 days. Here we can see the benefits from previous publications from our institution and also from the 3M study, where we can see, in comparison with previous studies and publications, that less invasive TAVR offers shorter length of stay, as we can see, and lower procedural mortality as far as those comparisons are concerned with previously published data. So less invasive TAVR is a current standard of care. And final comments, AVR with mechanical prosthesis may be associated with better long-term survival, fewer reoperations, and valve-related events. However, TAVR provides lower procedural and midterm morbidity and mortality, lower gradients, and larger effective orifice area than SAVR. TAVR has also shown significantly lower SVD and BVD rates than SAVR. BVD and SVD have been associated with higher all-cause mortality, cardiovascular mortality, and also need for rehospitalization. Unfortunately, none of the randomized controlled trials have considered patients' preferences and comorbid conditions in decision-making process. The choice of prosthesis depends on life expectancy, and at the present time, the standard of care would be for patients with life expectancy of less than 20 years, TAVR is recommended, and for patients with life expectancy of more than 20 years, mechanical prosthesis is recommended. Thank you very much for your attention.